Hello, this is a lecture, a pre-recorded lecture for Social Work 637 in the winter semester 2021. And this is for week 11. And the lecture topic is around crisis services, particularly here in Michigan. We're going to hear from Krista Hausermann, who works for the Michigan Department of Health and Human Services, working on crisis services here in Michigan. Krista?
Hi, thanks for inviting me. As Carrie said, I'm a strategic initiative specialist here at Michigan Department of Health and Human Services, Behavioral Health, Developmental Disability Administration. It's a long title. I work primarily on building out community-based crisis services. So I'm involved in a number of projects right now, as crisis services is a hot topic both at the federal level and at the state level. Just to give you a little background about myself, I have spent my entire career as a public services social worker, and I add that description as public services because I'm very proud to have been in and be in the public sector for social work. My passion is around social justice. So most of my experience in behavioral health services has been at the county level. I have a wide array of experiences from starting my career as a transitional housing program coordinator. I've also been a home-based family therapist, a collaborative coordinator at the county level, working on projects, facilitating a number of projects with cross-sector agency representation, mental health, courts, schools, etc. I also was a community mental health service program manager for services to families with children with severe emotional disturbances. I did that for several years. And then I also supervised wraparound for over 20. Then I moved to Michigan Public Health Institute and worked on a variety of behavioral health programs there, including a project around neonatal abstinence syndrome. I'd like to start my presentation today talking just a little bit about what we mean by crisis services. So when I think of crisis services, I think about services that support individuals, their families, when they are in a state of crisis as defined by that individual. When people reach out in crisis, they need immediate support of some type that they're not finding through their informal support networks. These needs, they're unscheduled, they're intense, and they vary according to the person. So what might be a very intense situation for one person may be something that's run-of-the-mill for another. Our crisis services system needs to support people no matter what their level of need is. They need to be allowed to define crisis themselves. That's an important component. So let me talk a little bit about our current crisis services system in Michigan. There we go. So right now in Michigan, our current crisis services, the array of crisis services is very much dependent on the payer, the location, and the severity of services. If you take a moment, look at your insurance card. What crisis service supports do you have? I have private insurance. I have very good private insurance. And if I have a mental health or SUD crisis, my option is to go to the emergency department. That's true for most Michiganders. The people that have Medicaid have a different array of crisis services, and they have a much more full array of crisis services, and they are supported by community mental health service programs. Right now, the entry points for our crisis services, and these are informal by default, it's default entry points. There's 3 of them: law enforcement, community mental health service programs, and emergency departments. You get my dog in the background. Sorry, I hope you can't hear him. I want to give you some statistics around law enforcement. There are no, I couldn't get any state statistics around law enforcement because 911 calls are not broken down by type of call. So here's some estimates on the level of involvement, like how many law enforcement calls relate to mental health. And these are from other states. So the percent of law enforcement contacts involving mental health, they range from 1% to 17%, depending on the source that you look at. And 1 in 4 people with mental disorders have histories of police arrest. And this one was really interesting to me as well, that 1 in 10 individuals have police involved at some point in accessing mental health services. So 10% of the population that gets into mental health services, somehow the police got them in, or the access was through law enforcement. The second entry point, again by default, are emergency departments. I will tell you that most emergency departments, especially the smaller ones, don't offer behavioral health services. They're starting to more and more, but they really don't have the capacity to support people with mental health issues. Again, it's just default because they accept all comers. So this is Michigan data. You can see that for the service type in Michigan, for Michigan emergency departments, psychiatric care was the #1 type of visit with 204,946 visits. It was followed by URI and asthma. It was also the highest in 2018 at 211,812 visits. I will tell you, when I first look at this statistic, which I got from the Certificate of Need Commission, I was surprised. And that's why I looked at 2018 and thought, maybe 2019 is just a fluke, but it's not. So you can see that a lot of people are going to the emergency departments. And when I have conversations in my stakeholder work, the emergency departments are saying most of these people are leaving with the name of a referral of a counselor, therapist, and but there's no follow-up to ensure that they got where the services that they needed to. The third entry point are the community mental health service programs. And there's a couple billing codes that they use. The data gets a little murky, but there's a couple billing codes that they use. Pre-admission screening is their screening of somebody with Medicaid's appropriate for hospitalization. And then they also offer many other types of crisis intervention services, which fall under different codes. And so you can see they had, for a period of about 12 months, they had about 100,000 crisis interventions. Now, I will tell you that some of those are at the emergency department and many of them are not. Probably most of the pre-admission screenings take place at the emergency department. For psychiatric hospitalizations, there were 70,391 psychiatric hospital discharges in Michigan. 14 of them, the CMHs were responsible to do some type of follow-up. What that means is for the other ones that they were mainly private insurance or individuals that for some reason didn't qualify for CMHS, for community mental health care. The other thing that I want to mention is we talk about this is the data is hard to get with crisis services too, because we as a system haven't been focused on gathering data around crisis services. Like as I said earlier, the 911 contacts aren't broken down by the purpose for that 911 contact, and that data is regional. So it's really hard to get comprehensive data on crisis services. There are also very few codes for crisis services. And so it's really hard to track that way in terms of using the data that way. So it makes it tricky. I want to show this slide because this is how crisis services look when they're integrated with other services. These are the crisis services that people can get if you're served by a community mental health service provider, if you have Medicaid, and see it says up here, chronic and severe. So the whole purpose of this pyramid actually is to show, again, the integration with crisis services. So if you're served by a community mental health agency, then through the services that you're getting proactive crisis planning. These services at the bottom, like ACT, home-based wraparound, other services. Basically, you're getting crisis planning through your care. And then as you take a look at this slide, you can see then there's a community-based crisis response. So this is the next level up of intensity, where there might be a hotline, a warm line, a suicide line, mobile crisis, and then here's some other crisis services. And then it goes up with intensity. I want to point out that the services in red are few to none. So for psychiatric residential treatment facilities in Michigan, we don't have those. For crisis respite, we have a few of those. And then some of the other ones like peers and recovery coaches that are involved in crisis response, we have some in different places throughout the state. You'll see case management over here, because case management, to be involved with supporting people, is a key element. And so this just shows you, though, again, this slide, I could spend the whole time talking about the slide. I don't want to do that. But this shows you how these crisis services are involved with other services. Again, like home-based wraparound, these are all regular services that people get, and they have a crisis component. And so I want you to think about, though, this array of services compared to if you don't have if you're not eligible for community mental health services. Then again, for people that don't have community mental health services, your options really are, you call law enforcement, you can go to the emergency department. So, as I was saying, right now is a really great time for crisis services. There's a lot of focus on transforming the system, both at the federal and the state level. In Michigan, we're focused on building a crisis services system, and I use the word system, rather than right now for all Michiganders. Right now, our services are very disjointed and not connected. For example, when I was talking about the emergency departments and the CMHSPs, there are some places in Michigan where there's a partnership between emergency departments and CMHSPs, but it's great, there's great disparity across the state. There's a lot of geographic variation. And so right now, currently, we don't have a system of care for crisis services. We have crisis services, they're just disjointed. And again, they're not integrated, except there are a few places where there's more integration. So again, we want to build a system. So for all Michiganders, regardless of payer type, regardless of where you live in the state, and regardless of level of need, because what we're recognizing is that there are people that are going through their daily life, everything is fine, they're managing, and then there's a confluence of events and it kind of pushes them into a state of crisis, and they need that support, and they need that support. It's, for most, it's a temporary support until they can regain that stability within their life. And so they don't need an intensive ongoing array of services. They just need services to support them during that crisis episode, which could be just a few days or maybe a few months. So again, our crisis services need to support everyone. So in terms of key legislative actions, I said that this is a time of change. It is. I want to mention a few things. There was actions, and I don't say legislation because some of these actions were discussions, and legislation came out of some and it didn't come out of others. So for them, a few years back, the legislature, in partnership with MDHHS, hosted a work group that met for quite a long time. And they came up with, basically the purpose of the discussion, was to address the lack of psychiatric care. And they came up with a series of recommendations, about 20 recommendations. And the department has been working on implementing them since then. Many of the recommendations did focus on supporting people that had more severe issues, and the focus wasn't on building a crisis system for all. But it did get us started about thinking about, hey, we really need to pay more attention to crisis services. So that was good. Things that came out of there were psychiatric bed registry, medical clearance protocol, and there's other things like maybe a standardized psychiatric referral packet. Michigan Cares Task Force happened about the same time. And that focused more specifically on access to care. How do people in Michigan know where to go for care? And there was some concern around that people don't know where to go for care. It's a really confusing place to try. It's hard to get behavioral health services in Michigan. And so there was a recognition of that. Out of this task force came one major piece of legislation, and it is PA 12 of 2020 for the Michigan Crisis and Access Line. And so the Michigan Crisis and Access Line is a statewide line that will offer chat, text, and phone for all Michiganders, and basically help connect Michiganders with that next step in care. They'll provide crisis triage, warm line type of support, and information and referral. But basically, any Michigander can call this number, get some support right then and there, if the phone line support or crisis triage support, and then connected to their next step. And it provides follow-up to ensure that that person got connected. And so then the other legislation, and I guess another piece of legislation that just occurred is PA 402 of 2020, and it's building out crisis stabilization units. And I'm going to hold off talking about those until I talk about the key building blocks of our crisis services system. And then the third piece that was really important is the 988 National Suicide Hotline Designation Act, which identified 988 as a 3-digit number nationwide that anyone can call to get help when they're feeling suicidal. So now let's talk about building the Michigan Crisis Services Continuum for All. There are 3 main building blocks to this system, and that is the call center hub, someone to talk to, mobile crisis teams, you can see someone to respond, crisis stabilization units, somewhere to go. This language that I'm using is also language that's used by SAMHSA. Our system is based on 2 key documents, the SAMHSA crisis services recommendations, those national recommendations, and the Crisis Now model. The Crisis Now model and the SAMHSA model are very, very close. So these are the 3 components that the federal government is recommending that are available for anyone. So this is, when you think about this service system, it's really important to think about it as a public good, like fire services and law enforcement. That's what we need to build out. When somebody's in crisis, they shouldn't have to look at their insurance card and try and figure out where to go. These services should be in place for everyone. So in terms of the call center, that's why I talked about the Michigan Crisis and Access Line. We're going live April 19th in just a couple regions in the state, the Upper Peninsula and Oakland County. We'll roll out to the rest of the state, statewide by October 2022. We'll roll out a region at a time. And historically, we have crisis line services in Michigan. And so historically, like right now, there's over 66 crisis lines in Michigan. And so you're probably saying, why add another one? It's because, again, it's that one number feature to say, here's one number that anyone can call. The other thing that's really important about the call centers and that SAMHSA is recommending is that this call center needs to be able to be strongly coordinated with other crisis services. It needs to be able to activate these other 2 crisis services. So in Michigan, our MyCal, which is what is called Michigan Crisis and Access Line, will coordinate care with people that are receiving care through community mental health agencies. It will also, and it will be able to activate the face-to-face crisis services that community mental health agencies offer, pre-admission screening and mobile crisis, and then the crisis stabilization units. It will also partner with other stakeholders, emergency departments and law enforcement, So it'll be a resource that they can give to other Michiganders when they're interacting with them, to saying, here's a place that you can call for support. Our hope is as well that people will reach out to Michigan Crisis and Access Line for help before things get severe enough that they need to call law enforcement or go to an emergency department. So this, again, now all Michiganders, if you have private insurance, you'll have MyCal and then the emergency department. So at least it's one more step. It's one more service in that array of crisis services. And so that's an important component. We are going to work, we are through the 988, there's a 988 grant, which is encouraging all states to do planning to ensure that we have capacity to handle all the 988 calls coming in. It'll go live, and the 988 goes live July 2022. And so that 988 grant says, hey, look at your current crisis services, look at your current call centers, make sure they meet certain standards and they coordinate. So through the 988 grant, we are going to work out coordination with other some of those other historical crisis lines that are interstate, and they take National Suicide Prevention Lifeline calls right now, and they'll take 988 calls. So we'll be working out some of those services, how to coordinate, how to ensure that any Michigander that would call those lines also gets the support they need. So, but Michigan Crisis and Access Line is that major service. And we'll see some of this transition over time. It always takes time. Mobile crisis teams, this service right now is offered in various places in the state. CMHs provide it to children who have Medicaid. Some CMHs provide it more broadly to other people in the community. Some provide it to adults. There is huge variation with this service, not only in who can receive this service, but also the hours. Some offer it from 8 to 5, some offer it 24/7, but also the location where that crisis team will go. Some may have very restricted locations, and some they'll go anywhere. Right now, we don't have any target dates to roll this out statewide. We are working on expanding this service through offering community mental health service programs, money through the SAMHSA block grant, some basically federal money to expand their services. The CCBHCs also have a requirement to provide mobile crisis. So many of them are providing mobile crisis. That's for everyone in their region. And so those are our most expansive areas where mobile crisis is offered. And we are looking to expand this service more broadly. So at this point, what we're doing is we're going to do some research around current mobile crisis teams, a model that will work in urban areas and rural areas, and look at how we really expand this service out and look for funding for that service as well. So we're in the process of basically under discussion of figuring out how we're going to gather that research and take a deeper dive, a deeper look at mobile crisis. Crisis stabilization units. This is Michigan recently passed legislation, PA Act 402 of 2020, requiring the Michigan Department of Health and Human Services to certify crisis stabilization units. And this is a big step in Michigan. I will tell you that this initiative is stakeholder driven. There's a lot of energy around this, and we are tackling this one first, the crisis stabilization units, before the mobile crisis, because there is a lot of energy around it. Other states have found that their diversion rate from psychiatric care is up to 60 to 70%, that they can treat people in the community. And treating people in the community is a much better option than hospitalizing them in psychiatric hospitals, because basically what's happening is you're communicating to those people that you as a community can support them and keep them safe in the community, and you're creating their safe place in the community. And the relationships that people have with therapists and other community services they're much more easily accessed when they're in the community than if you have to go to the psychiatric hospital to see the therapist that you connected really well with. So that's why crisis stabilization units have so much promise. So right now, what we're doing is, again, we are looking at ways to help get this stood up. There's no target dates right now for this. We have pulled together stakeholders to look at a Michigan model. And so we'll be looking at, to develop a Michigan model, sorry. And we'll be looking at other states' models and best practices out there to create a Michigan model for crisis stabilization units. The other thing that's really exciting about that is the stakeholder group that we have involves people from law enforcement, emergency departments, community mental health agencies, education, and people. Our key participants, people with lived experience, or people that are advocating for people with lived experience. And so this is an exciting service. The other thing that we're looking as we're looking at this model is it very much needs to be an integrated care model. It needs to serve people that have substance use disorder issues, mental health issues, and physical health issues. Right now, people can get bounced around. If your crisis stabilization unit only served mental health issues and couldn't even address any physical health issues, then people, there would be a concern if somebody went to a CSU and they had a physical health issue, they'd get bounced to the emergency department. Or if they go to the emergency department and get their physical health needs met, then they have to go someplace else to get their behavioral health needs met. So this crisis stabilization unit, the Michigan model, will be an integrated model. That's best practice. That's what needs to happen. So we'll mention that. Let me keep going. Oh, here's some references. Oh, so I guess that was my last slide, but I have other things that I wanted to comment on around crisis services in terms of, let me see, in terms of data sharing. And so when you think about how these services interact with non-crisis services, these services will interact with non-crisis services. Each of these services will be embedded in an entity that provides other services. The other thing, as we build them, we will mandate that they are integrated with other services. You can see there's a lot of support for that as well from the federal government and also from our state legislature. For example, the legislation around Michigan Crisis and Access Line says you've got to do care coordination with community mental health agencies, prepaid inpatient health plans, and other entities. That's a key part of that. So we will be building that care in. In terms of crisis services, HIPAA, the standards around HIPAA are a little bit different when somebody's in the state of crisis. HIPAA does allow therapists to share more information if that person's in a crisis, if it's in the best interest of that person. So for example, if it's to reduce suicide risk or prevent them from harming themselves or somebody else, they can share information about that person with a community service provider, or let's say a doctor, some type of emergency services. So that's a little bit different than the regular information sharing. It's really important when developing these services that we think through how we'll share information. So for example, Michigan Crisis and Access Line is an actor of the state. So it can share information, it can share mental health information back and forth with the community mental health service provider agencies. We are taking steps to be able to ensure that we can share substance use disorder treatment information, 42 CFR Part 2. Let me see. Oh. Then I wanted to talk real quickly about some of the challenges of setting up a statewide coordinated crisis system. I'm going to mention, the first one I'd like to mention are the historical service systems. So we have these historical providers, and right now there's a lack of coordination between services. There's large geographic disparities. And the thing is, when you're setting up a new system, it's hard for the people that are currently offering services to change what they're doing. Now, some people, they are able to do that and they can see where we're headed, but others, it's really hard to do that. One of the things that I've noticed when I work with the various primary stakeholders is that they get frustrated with other parts of the system. And there's a term I'd like to raise that I think is a barrier for us moving forward in terms of systems change. And it's vocational awe. They use it, libraries use this. And it's basically when people that are within a system recognize that the work that they're doing is so good, and it's really driven by their values, that it's hard to see that maybe where they need to change that service. So it's everyone that's doing this work, whether they're people that are working in the emergency department, law enforcement, or at community mental health agencies, they're all doing this because they share this passion, they share these values, and they really want to help people. So it's hard to really, so I think that the service work and their measure of how well they're doing many times is based on that energy that they're putting towards it and their values rather than the actual outcomes. And so I think that makes it a little harder to change our system. Another barrier is workforce. There are not enough staff in the public health systems at all. There's a shortage of staff in emergency departments, like community mental health agencies. And as there's more and more demand for mental health services on an outpatient basis, it's going to make that, it's going to make the crisis or workforce crisis even worse, because many people would rather have a 9-to-5 job than a job where you're working odd hours or 24/7. Financing is another barrier. Our current service system is more like a fee for service, or even with the managed care, it funds the actual services when they occur. It is not capacity-based funding. For crisis services, you need capacity-based funding. So if you think about the funding of a fire service, we pay firefighters to be available in case there is a fire. We don't pay them just every time they fight a fire. So we need the same thing for crisis services, like for mobile crisis. We need to pay them to be available all the time and not just pay them for the time that they actually go out for care. And so that's a really important difference. And so again, as we look to fund these crisis services, we are going to look at capacity-based funding. So those are the three main barriers that I would like to mention. And let me see, I think with that, I have a couple pieces of advice. Carrie gave me some questions to respond to. So advice that I would give you is that one of the key components when you're doing systems work is to involve and listen to people with lived experience. Systems designed by providers, they tend to be designed for providers rather than people who need the services. And those systems that are designed for the providers, the standards tend to be at the lowest common denominator. If you're involving and listening to people with lived experience, then you're really going to design a system that meets their needs, and your standards will be higher. Then my other second piece of advice would be to be open-minded about partners from other entities. What I find is there's great people in each service system, and we need to unite together to develop a comprehensive system. And so look at those people from other entities as your partners and develop those relationships. And that is my last piece of advice. So at this point, Carrie, do you have any questions for me?
Nope, you preemptively answered all of the questions I sent you. So thank you so much, Krista. I really appreciate this. This is going to be helpful for our students across all the sections of Social Work 637, and it'll be useful for students. As you can see, you know, even as they're graduating in the next year or two, they're going to be graduating into a world where there is a transforming and partially transformed crisis system already happening. So thank you for explaining all of that to us, and we really appreciate your time, and it's always great to hear from social workers in the field.
Thanks, Carrie.